Hello, and welcome to Chapter 13 in our course Introduction to the U.S. Healthcare System. Chapter 13 focuses on health policy and the role that health policy has played and is continuing to play in the development, revision, and the execution of the core functions of the U.S. healthcare system. And so in this lecture, what you're going to hear about is some of the definitions and the role in which health policy has played in the U.S. healthcare system, as well as talking about some of the distinguishing features of, in particular, the U.S. health policy system. We're going to talk a little bit about some of the legislative aspects about the way health policy is made, as well as talking about some of the key issues that are currently taking place in our healthcare system that are being addressed through policy. And lastly, we will talk about some of the basic components of the Affordable Care Act. So, where we begin is, what is health policy? Health policy, quite simply, is the set of rules and decisions that go into influencing or trying to change the behaviors and actions of either individuals or institutions. These decisions, these rules, can be made at the federal level, where we see the United States Congress, the House of Representatives, the Senate, the President making decisions. They can also be made in other areas, the executive area, such as state governors as well as the President. We also can see this happening in the judicial branch. We've had numerous instances where, for example, the United States Supreme Court has ruled on matters of health policy. These cases and these examples will be something that you go over in great detail in the law and public health class, for example. So there are many different venues in which health policy decisions can be made. But ultimately, all of the purpose of health policy is to change or influence the behavior and the actions of the institutions and individuals working in the U.S. healthcare system. So when you think about health policy broadly, it's that entire set of rules that govern how institutions function, the resources that they receive, and that ultimately steer and guide what the health of our population in the United States is going to be like. That's ultimately what the goal of all health policy is to ensure that our population is going to be healthy. That is ultimately the purpose of public health policy. There are many different forms of health policy that you will see. Health policies may be the result of certain kinds of social policies. So, for example, there have been numerous times when instances of welfare reform have taken place that have actually impacted the health and well-being of the citizens who are unable to work in this country. And so you can argue that there are health policies actually in all policies. And this has been a new movement that has been taking place in the public health and health care delivery communities to talk about that it is essential to consider what the health implications of not just policies like the Affordable Care Act, or not just policies that are set by the Center for Medicare and Medicaid Services are, but in fact in all social policies, in all transportation policies, in all policies about the environment, that we really ought to be aiming for health in all policies. And that's actually the theme of this year's American Public Health Association annual meeting, which is to really try to bring in and integrate and acknowledge that health and well-being of individuals in the United States and really around the world isn't just dictated by the health care that they receive while they're in the hospital or in the doctor's office. In fact, health is determined by a wide range of factors that we'll talk about in Chapter 3 and Chapter 2. We'll be able to see that, in fact, health is comprised of many different components, most of which have very little to do with specifically healthcare delivery. And so what we see is that a health and all policies approach means that we need to be attending to the policies that are made, not just in the public sector and the things that government controls, but also policies that affect the private sector. Now, of course, there are different kinds of health policy. There are specifically two large categories. One is regulatory. Regulatory policies set the rules and the standards for how institutions must behave. These are a lot of the rules that you may be familiar with that are being set by the Center for Medicare and Medicaid Services, or policies being set by the Centers for Disease Control and Prevention. They set the boundaries of appropriate behavior and put in place either fines or punishments or even rewards or incentives for ensuring that people behave in the ways that the policy intends. On the other hand, you have allocative policies. Allocative policies do kind of what they sound like. They allocate resources on the basis of actions or behaviors that are consistent with what the policy intends. So we have two large categories of allocative policies. One are distributive and one are redistributive. Distributive policies take funds that the federal government has and distributes it to all players, all people within a certain sector of society. Redistributive policies in health policy actually collect and gather funds from one group to give it to another. So depending on the policy, we may have one that is purely distributive, or we may have one that is redistributive. Redistributive policies are typically designed to redress or to deal with certain inadequacies or shortcomings in the existing allocative or distributive system. So that's typically how that works. So here below, you have a series of public health policies which sort of fall in these various categories. So reforms in medical education is a public health policy that is largely regulatory. We see the enactment of the Centers for Medicaid and Medicare Services, the enactment of these systems was both regulatory as well as allocative in terms of being distributive. If you'll recall, when the way that the Medicare and Medicaid systems were set up, and particularly the Medicaid system, states were offered the opportunity to set up programs in which they would set the conditions by which people would have access to the Medicaid system. And in exchange for setting up those programs and having them function according to certain rules, there's the regulatory component, then the federal government would award funds in the form of block grants to those states to help fund those programs. That was a distributive portion of the policy. So that's a great example of where these two kinds of policy often overlap or reinforce one another. There are many other kinds of policies that govern things like hospital mergers, the procedures for licensing physicians, banning smoking, monitoring sanitation in restaurants. All of these different kinds of rules that are being set are different forms of health policy. There are some key features that really distinguish health policy in the United States. We are going to talk about and define health policy generally, but it's also important to understand that a lot of what we're going to talk about and what we see in health policy making and in the execution or implementation, as it's typically called, of U.S. health policy, that it is very different than other nations, just as most other things about the U.S. healthcare system is very different. So first, what we see is that health policy making is very fragmented. And part of the reason why U.S. health policy making is very fragmented is as a direct result of the structure and the function of our government system itself. So as you may know, and you'll learn about this in greater detail again in the Law and Public Health class, as you may know, we in the United States, we have what we call a federalist system of government. The federalist system reserves certain powers for the federal government in Washington, D.C., and any powers that aren't specifically reserved for the federal government are always the province of the states. our individual 50 states. So, as you can see, just the structure of this system alone means that there's going to be fragmentation. There's going to be certain efforts that are being made in Washington and certain efforts that are being made in state capitals around the country. It's difficult often to coordinate and get all 50 states on board with doing the same thing. And so we have a very fragmented, disjointed system. And it's very rare that actually states are able to come together and all do the same thing at the same time. What we also see is that the U.S. health policy process is extremely incremental. Because of the size of our government, because of again, this federalist system and the 50 states that compose the one United States, what we see is that the process of making change in the health policy system is incredibly slow. What we see, and this was exemplified over and over again in the lecture about sort of the history and the evolution of the U.S. healthcare system, is that as proposals for reforms come forward, they are done in a very piecemeal fashion. We were not able to, and we still have not been able to reform the entire U.S. healthcare system such that all people have access to health insurance, right? Over the span of a century, we've seen changes happening in the U.S. healthcare system that have moved us closer to universal access and now having an individual mandate. But this has been a very slow, very hard-fought process. What we also see is that our U.S. health policy system is very pluralistic in the sense that there are literally hundreds of different interest groups that actually are able to exert quite a bit of influence on how a health policy is formed. There are a wide range of these organizations that are able to exert their influence and actually have a big role in how health policies are written and ultimately executed. We also see, again, this decentralized role for the states. Many of the health policies that are taking place and being executed at the federal level then have to be translated down at the state level. That sometimes is something that is a process that is fraught with complications. We also see that there's considerable role for the impact of presidents, and there's a slide a little bit later in this presentation that talks about the major role that presidents have. And lastly, what we see is that policy interventions often begin with what is broken. Rather than imagining or envisioning what an ideal system would look like and building it, we're constantly patching up the holes of the problems and the things that are broken. So what we also see is that in the U.S. healthcare system, the federal government is often, as we talked about, patching those holes, trying to fill and cover up for the gaps that the private sector has left. Because most of our healthcare is being delivered, at least, if not financed, by the private sector. And so many other policies and industries impact health from the private sector. What we see is that the government often has to step in and tell private sector companies or tell individuals practicing in the private sector, we have new rules for you. You need to do this differently. So those kinds of invention includes things like environmental protection legislation, setting guidelines and standards for preventing the spread of communicable diseases. When the CDC steps in, for example, and gives guidance about how to screen for and how to diagnose certain infectious diseases. That is where the government is stepping in and acknowledges that in the private sector, each individual hospital is not going to be able to develop a protocol for monitoring and identifying and treating cases of Ebola, let's say. So what the federal government does is it steps in and says, here's the guidance. We know all the most current research. We know everything that needs to be done. We are going to step in and we are going to provide you with these rules and regulations for how this is going to be done in the private sector. And so that's often a very important role. The government often also fills in the gaps where there isn't any market incentive. So the care for special groups, the care for the mentally and chronically ill, these are often groups where there wouldn't be a lot of financial incentive to try to find new treatments or to build institutions. So the federal government steps in and does that. The federal government also provides most of the motivation and the resources for research and development, as well as training of new physicians, new scientists and researchers. So that's another big role that the federal government plays, filling in the gaps of what the private sector, due to market forces alone, will not do. What we also see is that there are some considerable problems with government sort of stepping in and exerting its power over the private sector. And so what we see in the United States is really that the private sector is still king. Even though the government pays for so much of healthcare, the delivery of healthcare is primarily happening in the private sector. So when the government steps in and starts monkeying around with how the private sector does things, there can be some problems. So sometimes the federal government, of course, is very large. It's very bureaucratic. It's a lot of rule following. It's not very flexible. Today's healthcare system needs to be very nimble. Hospitals and other healthcare organizations need to be able to change to reflect the times. But a lot of times the federal government ties their hands and says, no, you can't make this change. You can't do this way because we've set rules to govern you. And if you want our money, if you want our allocative resources, you have to abide by our rules. Sometimes there are just too many rules. Sometimes there's too much paperwork. Sometimes there's conflicting guidance from one branch of the government or one federal department to another. So there's lots of issues that haven't been resolved sufficiently in terms of the government's role in the private provision of healthcare. There are also a number of problems that have come about that the government has tried to solve but really has been inadequate in doing so, including issues related to fraud and abuse. There are billions of dollars a year lost that the federal government spends trying to identify and catch the fraud and abuse that is taking place in our system. And that fraud can include things like inappropriate billing to Medicare to try to get more money from the government. It often can include simply documenting false things, not having the actual number of patients you have, a wide range of things that are not accurate, that are in the category of fraud and abuse. And you will actually, if you go out and look, there are dozens and dozens and dozens of news articles about various hospitals and health systems that have been fined for engaging in this fraud and abuse. A lot of times there are denials of claims, there are reimbursement problems, and so there's all this back and forth with either the state or the federal government trying for hospitals and healthcare systems to get payment from the federal government. This has been a big challenge in the United States. What we also see is that there's a lot of dissatisfaction with this sort of governmental or perceived governmental intrusion in the provision of healthcare. This role of the federal government in particular, but also the state, intervening in the provision of private healthcare, again, if you think about the history of the U.S. healthcare system, is very, very new. Once we entered into this era of sort of government dominance, we really saw that providers and consumers became very unhappy with how the healthcare system was being provided. Back in the earliest part of the 20th century, what we saw was that most healthcare was being just provided by the local town doctor, and you paid the person cash. There weren't these huge health insurance systems. There weren't these sophisticated government programs. And people were really happy with their health care because they had a personal relationship with their doctor, and they went to the doctor, they paid that doctor. It was a much personal, it wasn't this huge bureaucratic system. Now that we have that system in place, people are very unhappy about how their health care is being received and don't really know what to do about it. We also see that many government programs designed to help people who need access to health care, actually in the way that they were designed, there were major flaws such that people ended up becoming dependent upon those welfare and other kinds of assistance programs rather than creating the incentives to get people to go back to work or to get their children off of these programs. So it's really, there are many, many problems over the years that have developed with the government role in healthcare. So what we see is that we've really struggled to get the public and private sector to work together in a way that has been functional. And so as a result of that, because of this power struggle and because of this lack of coordination and the very complex and fragmented, in particular, financing structure we have in the United States, we've sort of seen this division within the system. We've seen that there's sort of the voluntary insurance that employers offer and that employees take, and that system functions in one way, and government up until now really hadn't been very involved in that system at all. And then we saw that there was a significant amount of government involvement, obviously in the government organized and operated programs such as Medicare and Medicaid. But what we see now is, in fact, that the federal government has a role in all forms of health insurance because of the Affordable Care Act, which we'll talk about in a few minutes. And so what we see is that now, in order for any change to take place, it's an even slower, more incremental process. We also have the role of interest groups, as I've already mentioned. The policy community is really comprised of the following entities. We have the executive branch, and this is true whether at the state or at the federal level. We have the legislative branch, the Congress. We have the executive branch, which is either the governor of a state or president. And then we have private interest groups, which includes everything from lobbying organizations, local area hospitals, patient groups, all of these other groups exerting their influence on the other two branches or pieces of the policy community. And so what we see is that increasingly the executive and the legislative branches of government have really become subservient or working in the service of private interest groups. And that's created some serious issues for how healthcare policy is made. We also know that the role of the state is somewhat of a challenging issue. Individual states often take a lead and don't wait for the federal government to make their own changes in the healthcare system, and really work very effectively to make change in terms of how their systems are run. They have a major role in a wide range of various functions in the healthcare system. They're responsible for ensuring the licensure and credentialing of healthcare providers. They're responsible for quality assurance and making sure that all the health institutions practicing or that affect human health in that state are high quality and functioning according to the rules, both of the state and the federal government. They authorize a wide range of public health, local government health services, such as vaccination programs, such as restaurant inspection programs. They are involved in a wide range of things that the federal government doesn't do. And now they're even involved in regulating how people access the healthcare system and how insurance carriers or insurance companies are creating their policies and how people access the healthcare system. We see that even in the state of Connecticut, we have an office for healthcare access. We also have an office for the healthcare advocate. Those offices you have different functions relating to how insurance plans are designed and operated and sold. There's also an office that's related to ensuring that all populations have sufficient access to healthcare in the state of Connecticut. So that's an example of where the state is involved, both on the insurer side as well as on the patient side. What we also see is that there's been a huge impact on the U.S. healthcare system on the part of presidents. Obviously, the most obvious one is the Affordable Care Act, which is also known in many circles as Obamacare, because this was President Obama's major legislative initiative and success in his presidency, many people would say. But other presidents before President Obama also played a big role. Harry Truman passed the Hill-Burton Hospital Construction Act, which resulted in most of the hospitals that were built in the mid part of the 20th century, and really resulted in the modernization of the modern American hospital. That was one of his major efforts. Richard Nixon had created huge federal programs for the creation and the operation of health maintenance organizations, or HMOs, in the early 1970s, and really moved forward and really wanted to, which I think surprises many people, really wanted to have a national healthcare system that would provide health insurance and access to healthcare through these health maintenance organizations. So he was one of the presidents. Usually we think about Lyndon Johnson, we think about FDR, but actually Richard Nixon was the president in the second half of the 20th century who was closest to having a universal healthcare system. So this is, again, something that it's worth noting, that the role of presidents has really been vital at the national level to advancing health policy in the United States. Obviously, part of President Johnson's Great Society was the passage of the Medicare and Medicaid Act as a revision to the Social Security Act of 1965. So what we see is at the executive level of government, there's a lot of influence, but we also see that legislatures take a huge role in terms of changing health policy. Legislatures often have more direct inputs from the people. They're supposed to represent the people as well as the interest groups. And so they often have a much better handle on what is happening in their respective states and what's happening across the country. But they also get a lot more input and influence from lobbyists and other private sector groups. And because of our bipartisan system, as well as the process that's used in our legislative system, the ability to make change is also very slow. The connection between policies being formulated and how they're implemented is often very disconnected, because how a bill is written in Congress, it's not up to Congress to execute that bill. It's up to some other part of the federal government, whatever agency is given authority over that piece of legislation. It's left up to them to implement it. And so what the original vision of the legislators in Congress was, and what the actual interpretation on the part of these federal agencies is, can sometimes be very different and result in problems. So what we see is, again, there is this very partisan or political piece of this. Obviously, this is a political system we're talking about. And so the ability to make change is usually very difficult and results in only being able to make these very small incremental changes in health policy over time. Now, it's very important to note that policy changes just don't happen. It's not that some legislator wakes up tomorrow morning and says, I think we need to change the way that healthcare is delivered or financed in this country, and it happens. There is a well-documented in health policy circles, and there's a great book by Kingdon that actually goes through every step of this policy cycle, which makes it very clear that there are 5 steps to the policy process. And they are, first, issue raising, or sort of setting the agenda on which we begin to understand that there is a problem in the United States. So for example, when we think about issues related to medical errors, 400,000 people in the United States are killed each year due to medical errors from the healthcare system. In 1999, the Institute for Medicine wrote a report called To Err is Human, which was the first time that a comprehensive review of the amount of medical error happening in the U.S. healthcare system had ever been done. Once that report was released, and it was shared with the public, and it was shared with legislators, then it became very clear that the issue of healthcare quality, and particularly of medical errors, was now an issue that was going to be on the national stage. So that IOM report was the event, the focusing event, that put this on the national agenda. Then, after it became a part of the national discussion, we then moved to a phase of policy design. So then the question is, well, we know that this is a major issue that the political system needs to resolve. What kinds of policies can we create to make that change?
Once the political process has gone through its process of deliberation and revising and settling on a policy that that group feels is the best solution for the problem, then you have to go through a phase of public discussion and public support building that allows for the broader U.S. public, whether it's at the state level or at the federal level, to buy in to this policy. What we see then after that is that the legislative process has to actually carry that bill, that piece of legislation, from it being a policy proposal that has significant public support through the various committee systems and all the various votes, and you have to gain support for it in the policy or the legislative system. That includes government agencies, it includes other legislators, it includes throughout all the committees that have to vote on it. Ultimately, a vote takes place, and if a piece of policy is passed, then it is decided on, and then it is handed off to whatever agency or part of the government is responsible for implementing it, and then implementation takes place. So that's sort of the policy cycle and how things are changed in terms of health policy in the United States. So obviously one of the major issues that we have faced in the United States up till this point is access to care. I think most people believe that all Americans should have a right, a guaranteed access to health care, and that all citizens should have a right to the same level of care, and that there is a basic minimum floor of care, right? So this is a great example of when it became clear that there were many Americans who did not have access to insurance, when the statistics became being released that there were 20 million, 30 million, 40 million people who did not have access to health insurance, and that number was actually growing. And through bad economic times, that number grew exponentially. What we saw was that Americans began to say, well, this isn't fair because I now know someone who doesn't have health insurance or who faced a medical bankruptcy. And so what we saw is that sort of all came together until there became a very clear awareness about the fact that most Americans, or many Americans, don't have a regular way to access health care, and that there are big disparities in the system. And that's what sort of set us down the path of beginning to think about how to reform the U.S. healthcare system. Obviously, there are already many existing programs and policies to deal with the fact that many groups do not have an easy or reliable way to access healthcare. There's already a huge public financing system in place. So when we think about the question of how are we going to reform the U.S. healthcare system, we're not starting with a blank slate. We're starting with this giant list of programs that are designed to provide support to people who would not be able to support themselves and get their own health insurance otherwise. So when we talk about changes to the U.S. healthcare system, often we're talking about changes to all of these various pieces of the public financing system that are all intertwined. So we have the Medicare system for the elderly. We have the Medicaid system plus the state children's health insurance program, which is either usually called CHIP or S-CHIP, which is designed for poor children whose parents don't have access to health insurance. We also have a program for poor adults, which is the Medicaid system or other state and local kind of assistance programs. We have programs designed specifically for persons with disabilities. We have all kinds of resources for veterans, for example. We have the Veterans Medical System, including the VA right down the street from the University of New Haven. We have the Indian Health Service, which is an entirely separate healthcare system designed for Native Americans, and that is only used and accessed by Native Americans, and that is delivered by the federal government. What we see also is that there are specific programs that provide public funding for people who have specific conditions. So people who have kidney disease, who are diagnosed as being end-stage kidney disease, they get special access to benefits through the Social Security program, which is often executed through the Medicaid program, including benefits for dialysis and for transplants. So when we say we want to make a change to our healthcare system, often it includes one, if not many more, of these other pieces and programs that are already in place. So as you know, health insurance reform has been very difficult in the United States. We are still the only industrialized nation that does not guarantee universal access to basic health care. And the Affordable Care Act was really designed to be, and really was intended to be, the piece of legislation that would change that. We have come closer to changing it, and in fact, we do have a system that is supposed to require all people in the United States to buy health insurance. But whether or not, in fact, that will come to pass and all people in the United States have health insurance remains to be seen. It is not the same, as you will learn about in a few minutes, as the other national health insurance systems or national health systems that exist, where everybody is guaranteed access to the healthcare system no matter what, no matter whether they've bought health insurance or not. It is, of course, a requirement of residency in the United States that you have a health insurance policy, but if you don't have a health insurance policy, there are exemptions, there are waivers, and then small fines that are being given to people, such that if you elect not to buy health insurance, there are some disincentives, and we'll talk about that more when we do our discussion of the Affordable Care Act. And so what we see really over time is that, and this is true when we talk about the history of the evolution of the U.S. healthcare system and the Affordable Care Act, is that states often took the lead in making changes that we talked about in the discussion about both Oregon and Massachusetts taking the lead in reforming their healthcare delivery systems. What we saw is that sometimes states and very proactive governors will decide we're not going to wait for the federal government anymore. We're going to go out and make these changes for ourselves. In the 1980s, President Reagan, another president who really felt strongly that the healthcare system needed to be changed, he really felt that the change that was necessary is for states to have more control over the financing and delivery and regulation of healthcare, and that the federal government should get out of this business. And so what he designed was a system by which block grants would go to states so that they would be able to execute and reform their healthcare system more effectively. And of course, states do have very large and important roles in regulating the health and protecting the health of individuals living in their state. So it is the state's responsibility, and most health regulation, in fact, is happening at the state or local level. That's where we set the policies about workplace safety. We set many policies about housing, food, and water. And in particular, it's the job of the state to enforce those policies, even if there are some federal guidelines or rules that exist. It's the job of the state to ensure or assure that all people in that state are being sufficiently protected. They also have a major role in responding to disasters and promoting healthy behavior. So as you see, what we have in the U.S. healthcare system in terms of health policy is a very complex web of varying roles for the federal, state, and local government that gets combined and layered on top of private interests and the demands of those private interests. And so what we see is that the ability to make change in the U.S. healthcare system is incredibly limited, and when we are able to make change through that 5-step policy cycle, it's often very slow because of the way our government works, because of its structure and its function, as well as the number of influences from the private sector that come to play. Moreover, because we already have this big, very complex, unwieldy system, many people are afraid of just changing it all at once. And so there's this sense that we need to move very incrementally and very carefully and test as we go, such that we don't make a catastrophic mistake in this very precarious healthcare system that we have that is functioning, although not optimally, right now. So that's what we will talk about online, as well as discussing more in class, how the U.S. healthcare system functions as it relates to health policy. And part of the reason why I moved health policy, even though it's chapter 13, to the front of this class, is that so many of the issues we're going to talk about are governed by health policies at the federal or at the state level. So knowing and understanding why and how these policies get made is really vital, especially now in the Affordable Care Act era, to understanding why and what is happening in the U.S. healthcare system on a daily basis. So hopefully this lecture has helped with that, and I'll look forward to any questions or comments you have in the discussion board or in class.